Hi everyone, thanks for the nice introduction, Sam. And I've known Sam since I was an intern at Cornell, and he was one of the fellows in the intensive care. And he was the only intensivist who was so kind and gentle that when he rejected our transfer request to the intensive care, I came out more satisfied after our discussions than frustrated, which is not always the case. If anybody has been an intern, probably can understand what I mean by that. Is there a pointer here? Yeah, that's all right. So what's great? Sam asked me to do today and to talk about is sort of our experiences in patients who are in so-called disorder of consciousness. So those are patients who had some severe brain injury for any reason, either from a trauma, from a car accident, or from cardiac arrest, or any other reasons. And then when they're recovering, sort of they're stuck in these in-between states. We are not fully conscious, but we don't really understand the level of consciousness, and sort of elude some of the ideas and some of the concepts that we are developed in these patients, and how that can be related to cardiac arrest and patients who are recovering after cardiac arrest. So these are my disclosures. So I'm going to start with a case presentation. I'm going to present a couple of cases during my talk, and sort of just to demonstrate the magnitude of the problem, what we are what we are facing here today. So this patient had a skateboarding accident when he was 19 years old, and he fell backwards. He didn't have a helmet on, and it was very severe brain injury, a lot of bleeding in the brain. CT showed subarachnoid hemorrhage, subdural hemorrhage, interventricular hemorrhage. So these are all signs of very severe brain injury. And he was in the hospital for several weeks, 2 months, and at the end of the hospitalization, he was diagnosed being in the vegetative state, which means that he was not able to move any of his extremities. He was quadriplegic. His eyes were closed. He was not able to open his eyes, and he was unable to speak or vocalize or give any response to the environment. And he remained this state in a nursing home for 4 years. And in the nursing home, 4 years being in this state, his therapist, just by chance, discovered that if she or he holds up his hand, he's sort of able to control the ball of his hand and respond to questions using that method. The hand would fall either to the nose or to the belly. We had the privilege to admit him to our research unit and to see if, what's going on with this patient. And we were sort of suspicious, like, is this real? Is this not? It sounds quite extreme. So there he is.
And for now, are you in a hospital?
We can stop the video. So what the question was, if you didn't hear, is,
Belly for yes, head for no.
belly for yes, head for no. Are you in the hospital, or are you in a bathtub? And what I want to point out also, that the person who's holding the hand has a mask on and also a noise cancelling headphone, so the person doesn't have any knowledge about the question or the nature of the question, because there could be some conscious direction with the hand, so the person who's holding the hand has no knowledge of these questions. So what you saw is that simple command following, just to tell him touch your nose or touch your belly, he was 100% accurate using this method. So they developed some questions about his life, some autobiographical questions. Are you 10 years old? Are you 23 years old? Logical questions. Do you put on your sock before your shoe? Do you put on your shoe before your sock? And orientation questions. Are you in the hospital? Are you in the shopping mall? And using these questions, we tested him during multiple sessions using this yes-no method. And he was accurate 60% of the autobiographical questions, 70% of the logical questions, and 50% of the orientation questions. So this is sort of telling us that all of these are way above chance. So he is able to answer to these, but what is exactly his level of consciousness, what is his memory of all of these is sort of unclear. So what is exactly consciousness? So being from Cornell, I'm bringing the heritage of Plum and Posner, who's sort of the grandfather of consciousness and researching consciousness. And this is their book called the Diagnosis and Treatment of Super of Coma. This is now the 5th edition of it, just came out of this year. And this is the way they are defining consciousness. So we heard a lot of different approaches, how we can approach consciousness from philosophy or from other ways, but medically, consciousness is defined as the state of full awareness of self and relationship to the environment. So are we aware of ourselves and are we aware of what's happening around us? And clinically, the level of consciousness, when we speak about these states of disorders of consciousness, are defined operationally at the bedside by examining the responses of the patient to our questions to the examiner. So this is still the gold standard. The gold standard to diagnose is called the coma recovery scale. It's a clinical scale, and there are questions which sort of says, am I pointing to the ceiling? Am I pointing to the ground? Look to the red ball and look to the blue ball, or just follow a picture with your eyes and fixate on, try to see if the patient can fixate and follow it. So these are the disorders of consciousness, the way they are defined. So coma is also called an unarousable unresponsiveness. In this state, the patient's eyes are closed, and there's no eye opening, no seemingly sleep-wake cycle, there's no command following, there's no communication with in this state. Patients don't stay in coma for a long time. They usually, after a couple of weeks for being in coma, they start to open their eyes and they enter the so-called vegetative state. So in the vegetative state, the only difference between two coma is that the eyes are open intermittently. So for a couple of hours, the eyes are open, then it's closed. So it's seemingly, just by observing the patient, it seems like that the patient has sleep-wake cycles. But for any of these questions, to the examiner, there are no responses that would tell us that there is any understanding of the environment. And then there's the minimally conscious state, when the eyes are open intermittently, if we ask the patients to follow commands to do this or to do something else, the patient sometimes is responding, but sometimes not. So it's not consistent. It's reproducible, it's there, but it's not consistent enough. And especially not consistent to use it as a communication channel to use it as a communication method with the patient. Just for clarification, what's not part of disorder of consciousness is brain death and locked-in state. So brain death is the total cessation, as we heard earlier, of all brain function, including the brainstem, and by legal definition, that's equivalent of death. And locked-in state is a special injury to a part of the brain, which is called the pons, which sort of destroys all the pathways of motor pathways going out from the brain to the spinal cord, and the patient is not able to move. However, the eye movement centers in the brain are above that level, so the patient can move his eyes freely and can blink freely, and the rest of the brain is intact. So by definition, that patient is fully conscious. These patients can, using eye movements and blinks, can write books. This is one famous case from a French patient who wrote a book called The Diving Bell and the Butterfly, and also there was a movie made from this. So sort of to get into the concepts and understand when we speak about this, I like to use this cartoon. So what you see here, the disorders of consciousness are here in the left lower corner. So this is the vegetative state, this is coma, this is minimally conscious state. And then this is the x-axis is the cognitive function of the patient from total cognitive loss to normal, and then this is the motor function from total motor loss to normal motor function. And I want to highlight these two lines here. So this line is the consistent goal-directed function of movement. So if you imagine examining a patient in front of you, if there is no movement, then there's just no way to tell what's the level of consciousness of that person. So every response requires some kind of movement. So if the patient is not able to use the movement, then sort of where is in here under this line, is it the level of cognitive function? This is sort of impossible to tell at the bedside. Once there are movements which are reproducible, that's a communication channel right away. So if somebody can consistently, even just a flicker of the thumb can signal one way or the other one, there's a yes-no communication channel, and we can build on that and use computer interfaces or letter boards that can be used for communication and to assess the level of consciousness and the cognitive functions of those patients. So really the one problem and one question I want to concentrate on is this gray box, which is also called as cognitive motor dissociation. So there's a possible dissociation between the level of cognitive functions and motor functions in these patients. And that can range all the way from a minimally conscious state to it's called a complete locked-in state. So as opposed to the regular locked-in state, these patients not able to move their eyes, they're not able to blink either. But it's just at the bedside, we cannot tell what's the level of cognition is there. And the other set of questions is that some patients who are in coma or in vegetative state, with time, can improve even spontaneously. And traditionally, what we understood a severe brain injury after a traumatic brain injury, after a year, there's not much chance for further improvement. And after cardiac arrest, maybe after 3 months, there's not much chance for further improvement. But yet, there are a lot of patients now which we describe and we see who are getting better and emerging from minimally conscious state even years, sometimes even decades after the brain injury, and able to start communicating, able to start speaking, and recovering further. And what's the mechanism of this? How is this happening is really not understood well and not clear. So let's start with the cognitive motor dissociation. So really the landmark paper showing this was in 2006, published in Science. And it was a single case report using fMRI. So fMRI, for those who don't know what it is, it's a MRI technique and sort of measuring the blood flow within the brain. And if a brain area is active, then that part of the brain is using more blood and using more oxygen. So by measuring the oxygen level, we can approximate that brain area is active. And here, this patient was asked to imagine playing tennis. And as you see, the activity is almost identical to a healthy volunteer to control. And also was asked to just walk around his home, entering rooms and going all around. And as you see, the brain activity is almost identical compared to a healthy person. And this patient was in vegetative state, so appeared to be totally unconscious at the bedside. So that was very important. There was a follow-up study by Martin Monti. A couple of years later, a series of patients, 26 patients, and about 50% of them was able to do motor imagery. But there was one patient who was able to use motor imagery as a communication method also. So it says, is your father's name Alexander? If yes, then imagine playing tennis. If no, then don't imagine playing tennis. And they're able to use that kind of method accurately to communicate. Obviously, it's getting an fMRI takes a long time, so it's not the ideal way to use for communication. So is this a possibility in the setting of cardiac arrest? So we described a patient after cardiac arrest who was 16 years old, was playing sport, collapsed, had very prolonged cardiac arrest, prolonged CPR for 45 minutes, got hypothermia, and got a pacemaker afterwards. And we were able to see her and admit her 2.5 years after this cardiac arrest. At that point, she was alert. She was laughing at times. It seemed like there was some emotional responses to the environment, but otherwise was not able to communicate, not able to follow commands. And based on the clinical scale, her state was consistent with vegetative state. We couldn't use MRI or fMRI in her case because of the pacemaker. That's a contraindication for MRI. So we developed a technology to use EEG, so using the brain waves and sort of picking up the signal, following a command of using similar kind of motor imagery, tennis playing or swimming or navigation, and contrast the signal within the EEG to the time periods when the command is stop imagining doing that. And by contrasting these two signals, we can pick up signals of changes in brain activity in relation to the actual command. So this is her. So this is before the command period, and this is contrasting the signals after the command. So the command is keep opening and closing your right hand, and stop opening and closing your right hand, and we see significant difference over the left part of the brain during the response period, which is a little bit variable but consistently present for 9 seconds after the command. So she's able to do command following using this covert method, using this EEG. even though she's appearing to be vegetative at the bedside. What's interesting is that we couldn't get MRI, but we could get a PET. So PET measuring the metabolic activity of the brain. So what's more red here, that means it's more active, and what's dark, it means that the cells are not active there, they are not functioning well. And what's interesting in her case, what you see also here compared to 10 healthy volunteers, that the front of the brain is normal compared to healthy volunteers, and the back of the brain is sort of, this is quantification of what we see here in the picture as well, is sort of gone. So it's the same brain getting the same hypoxic hit during the same cardiac arrest, yet the front part of the brain survives normally, and including this spot here, which is the thalamus, which I'm going to talk about. The back part of the brain is not functioning, it's not there. So is this, all of these were in the chronic state, so is this possible in the ICU? So there are more recent studies, and there are 2 studies which came out very recently which brought this kind of technology into the ICU. So this was published in 2007 by Brian Adlow in brain. He was using fMRI, and in 8 patients tested in the ICU, an average 9 days after the severe brain injury, 4 of them in the vegetative state and 1 in minimally conscious state had command following using fMRI, which is a shocking finding, if you imagine that. And a more recent paper just came out this summer in New England Journal by Jan Clausen. This group uses similar kind of motor imagery commands by using a different kind of method to detect the signals that what we use, but regarding the same command. Is a large series of 104 patients, so it's a lot of patients in the ICU, and 16 of them, so 15% of those patients using this kind of method 4 days after the brain injury showed brain activation in relation to these commands. And so that's significant. And what's most important, and what I want to tell, that of these 16 patients, 8 of them regained consciousness by the end of the hospitalization, so 50% of them, as opposed to 26% of the other patients who didn't have this activation, and 7 of them, so 44% of them, a year after the brain injury was independently functioning, as opposed to 14% of the rest of the patients. So it's not just the detection of it, which is by itself. We should think about our patients who are in the ICU, or doctors who are in the ICU, seeing these patients. It's not just the detection of possibility of conscious awareness and command following, but also it relates to the outcome as well of the patient. So let's switch to the mechanisms of emergence from these disorders of consciousness. So this is, we are neurologists, we like brain localized the dysfunction of the brain and brain areas and brain circuits, and these are some brain areas which are classically thought to be related to coma and recovery of consciousness. It could be either in the brain stem or in the middle of the brain, in the midbrain, and especially the area which is called the central thalamus, so this is the central part of the thalamus, or in the cortical area. So this is the gray matter area of the brain, and widespread areas of these cortical areas, and the connections between the frontal part of the brain and the more posterior part of the brain. Also, these long-range connections are connected in between the central thalamus. So central thalamus appears to be a point in the brain which activity, if it's altered, then the level of consciousness can be related to that. So that sort of tells us a few ideas of what can we do for patients to allow them for their recovery of their consciousness. And one option is to stimulate the central thalamus. So that was done in 2007 by Dr. Schiff in 3 patients, a deep brain stimulator. So these are electrodes which are inserted into the central thalamus. Was inserted into patients who were in vegetative state and minimally conscious state. And one of these patients, in relation to the stimulation, to the deep brain stimulation, improved, including improvements in vocalization and being able to be fed by mouth as opposed to through a feeding tube. So that's sort of emerging from minimally conscious state, able to vocalize and back when the stimulator was turned off. Another option is automatically stepping forward. Another interesting phenomena is that there's a small subset of patients, a few percent of patients who are in minimally conscious state, and this was just discovered serendipitously. If we give them a medication called zolpidem, which is normally a sleeping pill, paradoxically, these patients who are in minimally conscious state can emerge from minimally conscious state when they get these sleeping medications. And one possible mechanism is that the zolpidem in that level is inhibiting the striatum. These are in the middle of the brain, which normally inhibit the central thalamus, but if they are normally overactive and they over-inhibit, so if we inhibit the functioning of these areas, that releases the normal functioning of the central thalamus. So that's one way that this would fit in our concept and model. Another option is to stimulate using a weak electric current the cortex, especially the frontal area. So this is called the transcranial direct current stimulation, and there was a study which was done in minimally conscious patients, and 30 patients, just a weak current, and that improved their level of consciousness using the coma recovery scale. And another major study that was done, the largest study done in minimally conscious patients using amantadine, which is it's a dirty drug. There are many different mechanisms of action, but one of them is dopaminergic. So there was a sort of widespread activation of the striatum and the cortical areas with using amantadine, and there was a significant difference between the patients who got placebo compared to patients who got amantadine over 183 patients. So how is that related to cardiac arrest and post-cardiac arrest coma? So Dr. Lewis already was very helpful, so I don't have to go through all of this again in the slides. So these are sort of the markers we use as clinicians to prognosticate patients who are in coma after cardiac arrest. So we use the clinical examination, myoclonus, reaction to pain, pupillary effect, corneal effect. We use all these EEG findings. I'm an EEGer, so if you see what we're looking is into reactivities. Is there any change in the EEG when we stimulate the patient? All these epileptiform discharges, and especially patients who go into status epilepticus or burst suppression. We already heard about those, and we saw images of those. Those are considered to be very malignant findings in the setting of post-cardiac arrest coma on the EEG, and traditionally the numbers to predict a bad outcome, if those are present, are there. So traditionally we think that patient is not going to have a chance for recovery. And also here is imaging and the biomarkers and somatosensory we will potentially discuss. So the problem is, if everything looks pretty bad, then probably the patient is going to, the outcome is not going to be that favorable. But what happens when there's a mixture of these? So the current approach is multimodal approach, so we use all of these to sort of assess the chances for recovery. But what if the patient has normal imaging but has status epilepticus or burst suppression and some other malignant findings? Then we're sort of not exactly sure, and the question is more complicated. So in that case, currently what is also taken into consideration is the length of coma, how long the patient is staying in coma. And generally the guidelines say that the more time goes by and patient is still not waking up, that the likelihood that the patient is going to wake up eventually is less and less. And the last recovery was described as 25 days. But most people who will recover, they will recover within the first week. If they're still in coma after a week, then the chances for recovery is minimal. And even if they recover and they improve for the year, they're going to remain in a dependent state and have a poor quality of life afterwards. So we had a patient who we saw, who I'm gonna wanted to bring in, the post-cardiac arrest patient witnessed collapse in the hotel lobby, had CPR, and ROSC, the return spontaneous circulation, was about 20 minutes, had hypothermia. So I had all the malignant EEG findings, went into status epilepticus, had burst suppression for about a week. The MRI showed a little bit of damage, not very extensive. A follow-up MRI was normal. Yet if you look at these EEG activities, so this is sort of summarizing longer segments of the EEG, looking into the frequency content of the EEG. So so this is low frequency, like the brain is working very slow. This is high frequency, the brain is working much faster. So when this is a straight line like this, it sort of tells us that there is not much activity going on in the brain. So what you see here is that at 1 month after, started to have spontaneous eye opening, so came out from coma to vegetative state. And at 2 months, started to be able to communicate reliably with nodding yes and no with the head, this patient, and moving her extremities. At 3 months, was able to speak, was alert and oriented, but was not able to stand up. And at 4 months, was able to pivot from the bed to the chair and was acute rehab. And the EEG activity, even at 2 months, was very, very minimal. There was this bump is some activity emerging, and at 3 months, the EEG shows much more activity. So the question is, what's happening to the cells? Why are they not active this prolonged time? So it's almost 2 months, and the cells are still not showing much activity, at least not what we can pick up with the EEG. So we have 2 more patients like this. I'm going to quickly just go through they are all outliers. Recovery of consciousness is more than 2 months with them, and they had very extreme findings, very prolonged burst suppression, absent reactivity, in status epilepticus for 14 months. And for this patient that I mentioned last time, who was in status epilepticus for 14 days, I should say, we had the chance to admit her twice, 7 months and 19 months after the cardiac arrest. At 7 months, had with his cognitive functions using attention tests, vigilance tests, orientation tests, aphasia screening, looking into memory, still very impaired. However, a year later, so 7 months to 19 months, all of these are maximized. So this improvement doesn't stop after a few weeks or a few months. If these patients who are in this state, maybe in coma for 2 months, they can continue to recover even 1.5 years after the cardiac arrest. So how is this happening is the question of the day, what we are discussing with all of these the presentations today. So this is our model of asking the same question. The cells who are here and sort of deciding their fate to go into cell death or towards recovery, what are the factors that can alter them to go into this way as opposed to this way? How can they intervene? And maybe some of these ideas from disorders of consciousness research can inform research of post-cardiac arrest coma as well. So I think I summarized all of this during my talks. I'm not going to read again my conclusions. And thank you for the attention. And these are all the people who contributed to this work.